Hi, and welcome to Complex Coronary Interventions from the Leeds General Infirmary. I'm Dr. Abdul Mosid. I'm a consultant interventional cardiologist. This is an interesting case of a complex RCA CTO treated retrograde via a degenerative vein graft which has been stented previously. So this is a 74-year-old man who had undergone previous coronary artery bypass surgery. He had previously underwent PCR to the vein graft to the circumflex obtuse marginal and had also had multiple PCR procedures to the degenerative vein graft to the RCA. He was in fact scheduled for native RCA CTO PCI after the last PCI to that vein graft. In the interim, he had occlusion of the vein graft to the circumflex and underwent PCI to the native circumflex CTO 6 weeks previously, and he is now attending for PCI to the native RCA CTO via the vein graft. So this is his previous coronary imaging. So his native RCA is a ostial or very proximal chronic occlusion. You can see this is the vein graft, which has been treated previously. This is the last procedure for stent occlusion, and this was treated with drug-eluting balloon. As you can see, there was still residual underexpansion of the stent, for which reason he was planned for intervention to the RCA CTO. It also, a few years ago, had treatment to the vein graft circumflex, which then occluded recently. So he underwent native CTO PCI, in fact, via the occluded vein graft retrograde. This was the procedure and this was the end result, which was good. So he has attended for the elective PCI to the RCA CTO. Access was 7 French right femoral and 7 French left radial. We took a 7 French multi-purpose guide to the graft and a 7 French AO1 guide to the native right. So we just checked the left coronary system, which looks good, with patent stents in the left main and circumflex, which were implanted recently. So we then moved on to look at the vein graft to the RCA. So the vein graft itself is patent, however, there is significant calcific disease distal to the anastomosis at the PDA-POV bifurcation. And on the REA view, you will see the ostial stent under expansion in the vein graft, and already there is significant restenosis, having had balloon angioplasty to this around 3 months ago. We then performed dual injections to clarify the occlusion and length. So this is a proximal RCA CTO. Occlusion length is around 25 to 30 millimeters. The proximal cap is relatively clear, although the course of the vessel after that is relatively ambiguous. But given the proximal cap appeared clear, we felt it was reasonable to start antegrade, knowing that we would very likely need to go retrograde. There is also a reasonable landing zone for antegrade dissection re-entry if this was felt to be needed. So we started off with a Gladius and a Turnpike spiral microcatheter. The Gladius is a polymer jacketed medium weight wire, which essentially is like a Pilot 200, but with steerable tip with the Asahi technology. And with some manipulation, we're able to also advance the corset, the Turnpike spiral, which is quite good for these ostial or proximal lesions where you need supported microcatheter, which can grab tissue. And you can see here actually the Gladius then appeared to cross through the proximal cap with the help of the microcatheter. So imaging via the graft showed that we're very close, in fact, to the distal cap, and certainly appears to be in vessel architecture. The wire may possibly be subintimal here, and you can see with manipulation it was not possible to cross easily. With deflection at the distal cap, which is likely to be heavily calcified. You can see the wires deflecting into a possibly a side branch. So at this point we advance the turnpike spiral, and you can see how good this microcatheter is for these osteal occlusions, as it is grabbing tissue and you can torque it through the occlusion without losing position. So advanced the microcatheter and then took a stiff confianza wire to try and puncture through this distal cap. However, again, the confianza deflected off the distal cap, and this was certainly not in the vessel architecture. And again, this does not appear to be in the correct course. So it looks very close in this view, but it's clearly finding the wrong channel. So we checked in a REA view also. And this appears to be in line, but again, the wire keeps deflecting from the course. So here we're trying to find a point of resistance and try to puncture there. So here there appears to be a bit of resistance here, and then the wire appeared to pop through there. However, again, with contralateral injection from the vein graft, you can see the vessel wire is clearly out. Again, this shows the importance of having imaging of the distal vessel. So at this point, we felt that we should move to retrograde. As you can see, there is some staining around the native RCA, possibly due to exit. So we left the antegrade microcatheter there with a knuckle wire to plug the hole, and we moved to a retrograde procedure via the vein graft. This was with a turnpike LP catheter. Initially, we're attempting to wire with a cyan black. This proved very difficult, in fact, and as you can see from this injection via the vein graft, it's very acute angle back into the native RCA. So in fact, we used a Supercross 120 microcatheter here, which has a angled tip, and this was very useful in directing us back up the native RCA with a pilot 200 wire, which was then easily advanced. And the pilot 200 was advanced to the distal cap, and then the Supercross was removed and replaced by a standard microcatheter, and this time the Turnpike LP, which is a very good retrograde microcatheter. And as it is a cord catheter, you're able to torque it through tough occlusions. You'll also notice here we have a 7-French guide extension from the retrograde to provide additional support. So we now have a very supportive setup, and we attempted to puncture through the distal cap. There's slight difficulty here, so we then bring an antegrade knuckle in just to clarify the course. So the retrograde microcatheter is advanced to the distal cap. Then formed an antegrade knuckle with a fielder XT. And this clarifies exactly where we need to go with our retrograde wire. So we then did a retrograde knuckle also. And again, chose to use a fielder XT. Which, as you will see, advances easily through the distal cap and into the proximal RCA, and this is very reassuring and a good setup as the wires and devices appear to be overlapping. So we then advance the retrograde turnpike LP into the occluded segment, overlapping with the antegrade microcatheter, and we are now well set up to perform retrograde reverse cart. So we plan to do this with an antegrade guide extension, so-called guide extension facilitated reverse cart. Before we did that, we just checked in a couple of different views just to make sure we are definitely overlapping. This is an important safety tip, because one view things may look great, but in another view you may find that you're in completely different space. So it is important just to do this before you commit to taking a large balloon. So this looks a good setup. So then proceeded to reverse cart. So this was with a guide extension, a 3mm balloon, and a gladius wire. So the balloon inflated and deflated, we're trying to wire the guide extension with the guide. The balloon is brought back a little bit and inflated again, just to make the connection. And once the balloon is deflated, we'll try and wire the guide extension. So the balloon is deflated, in fact the wire pops through, and in fact actually pops through into the aorta. So we have now crossed the occlusion. Now, rather than bringing the wire, there's two options now. You can either bring the wire back and attempt to wire the guide extension, although you may regret this if you get back into the occlusion and are able to complete reverse cart again. So in fact here we accepted this position and managed to advance the turnpike LP into the aorta, and we decided to perform snaring. So then a 300 centimeter RG3 wire with a umbrella shaped tip bend on the end was advanced out through the turnpike LP into the ascending aorta. We then brought an end snare on the antegrade guide to snare the RG3. So this is real-time snaring. As you'll see, it's very straightforward, especially when you have this setup with the microcatheter pointing straight at the snare. So the snare is brought back and then advanced back through. So the RG3 wire is brought back and advanced through the snare, which is then pulled back and grabs the wire. So this wire has been successfully snared. and this is then pulled into the guide catheter successfully. And we're then using this support, with traction, we'll advance the antegrade guide over the retrograde turnpike LP and attempt to engage the RCA ostium. As we're doing here, providing some traction, then forward push on the guide catheter, which is then torqued into the ostium of the RCA. Like that. So now we're in a good position with the retrograde mark catheter in the antegrade guide catheter. So we attempt to now pull out the RG3 with the snare. However, there was a significant resistance, and due to the tortuosity of the vein graft, it was not possible to externalize the RG3 wire. So unable to push on the RG3 or pull out with the snare. So this can happen when you have tortuosity. So the option then is to perform a tip-in maneuver. So you can do this either using the retrograde wire through the retrograde microcatheter and try to wire an antegrade microcatheter, which we tried here briefly. However, this can be more difficult if there is tortuosity with difficulty of torquing the wire. So you can see here, attempting to wire the antegrade microcatheter, there is little torque on the wire. So in fact, we remove this and attempt with a antegrade wire instead, which will have more torque as there is less tortuosity. So here we've got the two microcatheters perfectly aligned, and as you can see, first time the antegrade wire easily finds the tip of the retrograde microcatheter. We'll show you here again, and this was a cyan black wire and easily advanced into the body of the microcatheter. Following this, the wire is advanced through the microcatheter, through the body, and in fact all the way up back into the vein graft, which then provides a very stable platform to work. As you can see here. And then the retrograde microcatheter can then be withdrawn, as demonstrated here. Following this, once this is withdrawn, we then in fact advanced a balloon into the retrograde retrograde guide catheter to actually trap the antegrade wire, which provided good support to then advanced antegrade equipment. So you can see here there's a balloon inflated trapping the wire, and then we can then advance this balloon. So this is a 2.530 balloon, which is then used to dilate the native RCA and the occlusion. So the occluded segment is now being fully dilated, so we have successfully opened the proximal CTO. However, there is still a lot of work to do given the distal bifurcation disease at the PDA POV bifurcation, which appears relatively complex. So the way to then wire the distal vessels, once this is when the native proximal RCA has been dilated, will be to use a dual lumen microcatheter, as we'll demonstrate shortly. So we're just checking the balloon runs easily, so the twin pass dual lumen microcatheter will cross. So here is the twin pass has been delivered on the Antegrade wire through the dual lumen port. A cyan blue is then advanced, and we then attempted to wire the distal PDA with this wire. So the twin pass is brought back, and then the cyan blue is brought back slowly and attempted to then be manipulated into the PDA. However, this was in fact difficult, likely due to tortuosity caused by the graft anastomosis as well as the calcific disease. And in fact, it was not possible to cross easily. So we then used a pilot 200 wire, and this appeared to cross, although possibly with into a dissection. Although the distal PDA was noted to be very diffusely diseased from the outset. We checked during using a retrograde injection, the microcatheter is in good position, and we then used a workhorse wire to wire the PDA. So in fact, due to the worries about the wiring, we performed IVUS, and in fact, the distal position was true lumen. However, there was some subintimal passage in the PDA, so the wire appeared to be in and out of dissection planes. So we decided not to stent into the PDA. It proved difficult, very difficult, in fact, to wire the PLV from the native RCA. So in fact, we wired the PLV via the vein graft and then performed several pre-dilations via the vein graft. So we dilate the ostium, and again, there appears to be good expansion. And following pre-dilatation, we again had an attempt to wire the PLV from the native RCA, but again, this proved difficult due to angulations. So we then decided to commit to stenting the native RCA, but landing the stent proximal to the bifurcation, with the hope of then being able to wire the distal branches afterwards. So they appeared to be on the previous imaging landing zone before the bifurcation, or at least just to the carina. So the intrastent was advanced a little bit further in this view. We're working on the PDA wire, although we know there's some dissection planes into the PDA, so we don't really want to advance well into the PDA. So this is landed at the carina of the bifurcation. So it's the first stent positioning was performed using contrast injection from the vein graft. So this stent was deployed with good expansion. Then a second 4x38mm drug-eluting stent was placed from the mid to proximal vessel. Overlapping with the first stent, and you can see good expansion here. So we then performed a gentle contrast injection to see how much more stent is required. And prior to doing this, it is important to bleed back the guide catheter to ensure there is no air or thrombus, as this is the first contra injection we've done through the antegrade guide catheter since the start of the procedure. So following this, a third stent is placed at the ostium of the RCA. And this is positioned and implanted overlapping with the proximal stent with good expansion. So this is the angiogram after the stents. This actually shows well expanded stents, but as expected, there is significant distal residual bifurcation disease, which needs to be dealt with. Reassuringly, both the PDA and POV are patent. So we first performed post-dilations of the RCA stent with a 4mm NC balloon. And following this, we were able to wire the POV via the RCA, and then placed a stent from the POV into the RCA across the PDA, aiming for provisional bifurcation stenting. Positioning of the stent. This is a 2.75 by 12mm stent. The overlap was post-dilated, but this obviously needs further work for optimization, but this is the angiogram following the stent, which shows now a good result into the POV, and in fact the PDA is patent, albeit with some contrast staining. We then performed proximal optimization at the bifurcation with a 4mm NC balloon. Following this, we performed repeat intravascular imaging with an eagle eye catheter, and this is the IVUS one, in fact showing disease distal to the stent with a good sized distal vessel. The stent is undersized in the main RCA, requiring further optimization. So we performed further post-dilations of the RCA with a 4.5mm NC balloon. Post-dilating the whole of the stented segment, followed by an additional stent based on the IVUS, which is a 3 by 12mm drug-eluting stent. Into the distal PLV. So the stent deployed. and the overlap was then post-dilated. And this is then the final result, which looks very good. We've in fact, you will see TIMI3 flow here into both the PLV and PDA. The PDA does appear dissected, but the flow is good, so this was left alone. Thank you for joining us for this case presentation.